Well, good morning. We're going to reward those of you who got up early by starting on time, and I am really pleased that so many people did get up early to talk about burnout and to talk about how to improve practice satisfaction. And as I said, we hope to make this an interactive session, so please feel free to share with us your wisdom about ways that you found to boost your practice satisfaction. I'm Christine Sinsky, and this is my husband, Tom Sinsky, and we're both general internists in Dubuque, Iowa. And we have no disclosures. I wanted to tell you a little bit of the background about us so you have some context for our comments. We're both primary care internists. We've been in our practice for 25 years. I'm on the board of directors of ABIM. And we've had the chance to be part of national dialogues around primary care practice redesign through CMS Innovation Center, through some work with the VA, through the Institute of Medicine and NCQA. And we've also had an opportunity to be consultants to a number of private and academic medical centers as they're working to redesign the way care is delivered at the primary care level. And although our comments come out of primary care, what we've learned in speaking with others is that the challenges that our medical subspecialists face are very similar, particularly the challenges in the ambulatory setting. So that's a little bit about us, but I'd like to know a little bit about those of you who are here. So first of all, how many are general internists? The majority. And how many are medical subspecialists? A few. How about family physicians? Nurse practitioners? PAs? Okay. So, and I'm guessing most of you are from the East Coast because who else would get up so early in the morning? So our agenda this morning, we'll start out with a few framing comments around burnout, and then we'll spend the majority of our time talking about the results of a study that Tom and I did with others for the American Board of Internal Medicine Foundation called In Search of Joy in Practice. And we'll be talking about some of the innovations that we identified in that work, and again, hoping to hear from you along the way. I'd like to start out by introducing you to three good men. The first is Dr. Jim Deming. He was a medical school classmate of mine. And recently, he left his practice that he'd been in for about 24 years to do other work. And he said, I'm burned out. My nurse and I just couldn't keep up with all that was required. This is a high school classmate of my husband's. The first physician I showed you was the Wisconsin Physician of the Year a few years ago. This physician was the past president of the New Mexico Academy of Family Physicians. He also wrote to us in an email recently, I'm not really sure how long I can keep doing this. And this is a physician I had the chance to visit in his practice at the Massachusetts General Hospital, and he's given me permission to share with you what he wrote to me after I visited him in 2008. There is not much real time to listen to patients. The little things have become the big things. I fear our roles as healers, comforters, and listeners are being lost. Sometimes I think working at Starbucks would be better. Last fall, a study was published in the Archives of Internal Medicine about burnout. And what the authors found was that nearly half of all physicians in the United States are suffering some element of burnout. And that was particularly prevalent in family medicine, internal medicine, and emergency medicine, practices on the front lines of patient care. So why do we care about burnout? Well, when I'm feeling burned out, when you're feeling burned out, our care isn't as good. When physicians are burned out, we make more mistakes. Patients adhere less to our treatment recommendations when they come from a physician who's feeling burned out. We have less empathy for our patients when we're burned out. And a recent study that was in the ACP Observer that we got in our packets here at the meeting identified that less empathy is associated with worse outcomes in diabetes. And overall, when the physician is burned out, the patient is less satisfied. So the authors of the archive study asked the question, if nearly 1 out of every 2 U.S. physicians is burned out, it implies that the origins have to be rooted in the delivery system and in the environment itself as opposed to being a sign of weakness or personality characteristics in a minority of physicians, in a few susceptible people. So with that as an overview, I'd like to turn our attention to the study that ABIM Foundation sponsored, and to first highlight the co-investigators, including Tom Bodenheimer, who was the co-PI, and he's here at UCSF, and others. And also to tell you that we had the good fortune of having a remarkable advisory council. And this advisory council included leaders from almost all of the organizations that touch primary care, including ACP, but also the American Academy of Family Physicians, the American Academy of Nursing. We had IHI and ARC involved with this, TransferMed, as well as the VA. And we asked ourselves, in light of the dismal situation in which primary care has found itself, where trainees are choosing anything but primary care, where physicians in primary care are leaving their specialty at a much higher rate than physicians in other specialties, and where the rate of burnout is much higher, in light of that dismal situation, are there places in the country where primary care physicians and their staff are thriving, where the work of primary care is both doable and enjoyable as a life's vocation? And so we identified 23 sites across the country where we felt that patients were getting good care and where physicians and staff were able to enjoy the work. As it turned out, the vast majority of our practices were patient-centered medical homes, although that had not been an entrance criteria for the study. And you can see the places that we visited here. And one or another of us spent a day shadowing nurses and physicians at each of these practices and speaking with the leaders of the practice. Our lens was focused at the most granular level of workflow and task distribution. Who did what in the practice, and what was the sequence? We also looked at the physical and technology infrastructures, and how did the space and the technology either help or hinder the teams as they were doing their work. And so out of that, we identified 5 challenges that we felt were commonly encountered. The first, chaotic visits with overfull agendas. Second, inadequate support to meet the patient demand for care. Third, vast amount of time spent documenting the care and complying with administrative and regulatory requirements. The fourth, EHR implementations and design that push more work to the physician, work that might previously have been done by a receptionist, by a billing clerk, by pharmacy, by a transcriptionist, has now in many cases become the responsibility of the physician. And then teams that function poorly and complicate rather than simplify the work. So those were the 5 big common themes that we found as we visited practices. And what I'd like to do now is share with you some of the innovations that we found to address those challenges. So the first challenge, chaotic visits with overfull agendas. And the innovations here are all around planning ahead. Planning ahead with pre-visit planning, including pre-appointment lab, and then taking a systematic planned approach to prescription management. So the first practice that I'd like to tell you about is Fairview Clinic in Minneapolis. Now, Fairview is a large integrated delivery system in the Twin Cities, and they have undergone a system-wide care model innovation, a care model redesign initiative. One specific element of that redesign initiative is the MA pre-visit phone call. So in small moments between other patient care responsibilities through the day, the MA calls people who are on the schedule for the next day. And on that call, she goes over things that she would otherwise be doing during rooming. But if she does this ahead of time, it makes the flow go better the next day. And it also allows them to be better prepared for that patient's visit. So she clarifies the agenda. She makes sure that they know what the patient's goals are in coming in that day, so they're not caught off guard. She also does a medication review. And this, I think, is more effective when the patient's at home and they can look at their bottles and go over exactly what they've been taking. They do condition screens as a part of their routine rooming, and so she'll do this over the phone. She'll do the PHQ-2 for a depression screen, for example, and then have a conversation with patients about advanced directives. And then all the information that she's gathering while she's on the phone, she's also recording to pre-populate the next day's visit note. again, to decrease the amount of work that has to be done during the clinic flow. This is another example. This is at a satellite of Mayo Clinic at Mayo Red Cedar. And they have a process there where the nurses call the patients a week before their appointment. And they arrange for the patient to come in and get the appropriate lab for whatever their conditions are. So the patient has the lab a few days before they have their appointment. And that allows the patient and the physician and the lab to be all together at the time of the appointment, which means the patient can be engaged in shared decision-making to a greater degree because they've got the results right while they're together. So the care is better. It also means it eliminates all that post-appointment results reporting work, all the letters, the phone calls, the emails around those results. And so while the patient and the physician are together, they can work off current results, and then they eliminate all that turbulence of extra work after the appointment. And one thing that we've identified in other work is that for every 4 hours of clinic session, it's common for there to be about 2 hours of post-appointment results reporting kinds of work. And most of that can be eliminated with this pre-visit planning and the pre-appointment lab, such as Mayo Red Cedar has done. Theta Care is another large delivery system in central Wisconsin. And at Theta Care, the patient arrives to their appointment, their blood is drawn, and then they have developed systems so that within 15 minutes, the result is back to the office, to the exam room with the patient and the physician. Again, with that same goal of having better patient-physician communication and decision-making around those results, as well as to avoid all that unnecessary waste of work with results reporting. And at Theta Care, it's pretty interesting. They've almost made it a game so that when the blood is drawn, a bell rings, and anybody who's free grabs that blood sample, runs it to the lab, and runs it back. And it's kind of a little bit of a sporting event when you're there. Several of our practices have taken a systematic approach to prescription renewals. And they do this by organizing the prescription renewals around the annual comprehensive care visit. And so what happens is that at the annual visit, all the prescriptions are synchronized and renewed for the next year, all the chronic illness medications. And what that does is it prevents that practice from having to unnecessarily keep repeating the same work over and over again throughout the year as prescriptions randomly come due. This is one of the biggest sources of waste, I think, that we have in our primary care practices right now. As Tom and I have visited a number of practices outside of this study, we've identified that the most common situation is for a practice of 6 to 8 physicians to hire one nurse who does almost nothing but prescription renewals. And almost all that work can be eliminated by taking this systematic approach to prescription renewal. So in this work, we identified that it's most likely that doing this annual synchronized prescription management saves about 30 minutes of physician time and about 1 hour of nurse time per physician per day. And you might say, well, big deal, what's 30 minutes of physician time or what's an hour of nursing time? But if we convert that into appointments across all 350,000 primary care physicians in the country, that converts out to access for 80 million more primary care visits in the country. And we know that that then translates into other things we care very deeply about in terms of quality and in terms of cost.
What about higher risk medications?
Excellent question. So the question is, what about higher risk medications? Is this across the board? And what we've seen and what we do in our own practice is that we do an annual synchronized renewal for all chronic illness medications with the exception of high-risk medicines. So benzodiazepines, narcotics, don't do that. Coumadin, it's a little different story because it's watched so closely in the Coumadin clinic in most practices now. But you're absolutely right. You want to tailor it for the medication and tailor it for the patient, because there's a rare patient in my practice where we don't give an annual amount of the medication. In Iowa, we can give 15 months, a renewal of 15 months, which gives us a window to cover that annual between one annual to the next. Now, a patient comes in for 2 to 4 appointments between those annual appointments, and we may adjust a medication, and that's fine. We send the new prescription to the pharmacy with a note to cancel out the old. But at the annual appointment, they all get resynchronized. They all get re-upped, if you will, so that we don't have to keep repeating the same work over and over again. And if you look at your practice or you look at other practices in the country, that there is so much waste as those prescription renewals are coming in. And you might get a call for one, and then a week later the same patient's going to be calling in for another. Or the patient may have been in to see you, and 2 days later there's a phone call. And you can eliminate that work by this really systematic approach. Yes, sir?
So are you saying that all the patients in your practice, for instance, have their prescriptions expiring in July, or each patient goes for that 1 year period?
So it's each patient. So if the patient had their physical in July, they would typically then have all of them expire.
They go 15 months.
Well, yeah, in our case, they go 15 months. Some states allow 12, some states allow 15. There was one more question, then we'll move on. Yes? So that's an excellent question. The question was, who's putting in the orders for the EHR, for the pre-visit lab? And we've seen different models. In our own practice, we check off on a paper visit planner. At the conclusion of each visit, we check off what's needed at the next visit. So if it's a diabetic and you've made some adjustments, RTC 3 months, FPS, A1C. Patient takes that to the receptionist who puts those orders into the computer. I think that's the most efficient way. We have some issues with meaningful use now, meaningful use stage 2, which is going to require that be a licensed clinician. So a nurse could do that, possibly an MA in certain circumstances. At Mayo, because of concerns about meaningful use, they changed it, and the physician can't do this prospective planning with an order. So the physician leaves the note, the plan in the note, and then the nurse has to scour the note to find what the physician had planned for, and in that call ahead, then does the ordering. So I think there are different models. But the least effective model, I think, is to have the patient come for the appointment, then you order the A1C, and then 2 days later it comes back, and then you call them or write to them, and you don't have a chance to get their input. So let's move on. So the second challenge is inadequate support to meet the patient demand for care. And the innovations that we found here are all around sharing the care, and sharing the care with other members of the team. And the most robust models that we found had 2 or even 3 nurses or medical assistants per physician. This allowed for a more robust rooming protocol to be done by the clinical assistant. It also allows a lot of between-visit care around health coaching, care coordination, and panel management. So the examples here that I'd like to show you, this is Dr. David Eitram. He's a family physician at Mayo Clinic, and he and his 2 nurses designed what they've called the new model of nursing. And it's a 2-to-1 model. And it replaces what used to be a 1-to-1 model in his practice. And in doing so, they've moved from a physician-centric model of task distribution and responsibility to a team-based model. So his nurses have taken complete ownership of immunizations for the practice. He doesn't get involved in that. That's theirs. They do all of the cancer screening setup. They do all the diabetic, they do and they document the diabetic foot exam. They do lifestyle counseling for each patient at their appointment. And they have some nurse-only hypertension visits. And when we were up there and I asked the nurses, well, what's different now for you? And they said that even though they can offer 25% more visits each day, that is, they can offer access to 25% more patients, they feel less harried at the end of each day, because of this organized approach and this way that they share the responsibility. And they are justifiably proud of the care that they can provide their patients. And they cite the fact that now when a diabetic patient falls off track, they can proactively outreach to that patient and bring them back in and help to prevent some of the devastating consequences of untreated diabetes.
Are they RNs?
One's an RN and one's an LPN.
The next challenge to joint practice that we discovered was the vast amounts of time that's spent documenting care. I think often we feel we're spending more time documenting the care than actually providing care to our patients. This is something we heard from a primary care internist in Alaska. I used to be a doctor, now I'm a typist. This is a picture many of you have probably seen before. It's from 1891, and it's entitled The Doctor. And I'd like you to just take a minute and look at the picture and think about what you see here. What we see when we look at this painting is the undivided attention that the physician is providing for the patient. Well, this is a portrait of the doctor in 1891. This is a portrait of the doctor in 2013. I think the undivided attention is going someplace else. The innovations we found to deal with this particular challenge included in-visit scribing and also assistant order entry by other members of the team. This is Dr. Peter Anderson of Newport News, Virginia. When I visited Dr. Anderson's practice, he told me that about 10 years ago, he was on the edge of burnout. He was spending more and more time at his office seeing fewer and fewer patients. He told me I was becoming a ghost to my family. He knew he had to do something different or he was going to leave his practice. He went on to develop what he calls the family team care model. And this picture really captures the team care model. You see the physician providing undivided attention to the patient while the nurse is in the room with him, assisting him with much of the other work that needs to be done. When I visited his practice, I really experienced what I think all of us hoped for and dreamed about when we were medical students and residents. Dr. Anderson spends his days listening to his patients, talking with his patients, and making medical decisions, doing physician-level work throughout the day. And he's able to do that because he has a very strong team of 3 nurses working with him. When I talked to Dr. Anderson, he said the real breakthrough for him came in designing his new model when he realized that there are really 4 components of the outpatient visit. First of all, there's data gathering, organizing, and documenting the data. Then there's analysis of the data and the physical exam. Third, there's medical decision-making and creating a plan for the patient. And finally, there's implementation of the plan, order entry, and patient education. And he came to realize that really it was only the second and third components of the visit that needed to be performed by the physician, and other members of the team could take care of the first and fourth components of care. I'd like to just take a minute to describe what it's like for a patient when they come to see Dr. Anderson. And I want to emphasize here that the nurse is with that same patient throughout the entire visit as their advocate and as their escort. So the patient spends the first 8 to 12 minutes with the nurse. And during this time, the nurse gathers, organizes, and records information. This includes the vital signs, medication reconciliation. She prints up the previous 2 visit notes to put this visit in context of the recent past. Also, any recent emergency room notes or consult notes, any recent lab or x-ray results. She then spends time with the patient, ensuring that the patient's agenda for that visit will be met. She performs and records the history of present illness for acute problems, and she also performs a guided and appropriate review of systems guided by templates. So all of this information is gathered, organized, and much of it recorded in the electronic health record before the physician enters the room. Dr. Anderson then comes into the room and joins the patient and the nurse. At this time, the nurse gives the verbal report to Dr. Anderson. And it's much like you would see a resident giving a report to an attending physician on hospital rounds and training. Dr. Anderson carefully listens to the information that the nurse is providing. He has further questions for the patient, interacts with the patient. He then goes on to perform his appropriate physical exam, and then he makes his medical decisions. He verbalizes any medication changes, any lab and x-ray orders that he wants, the diagnosis and billing codes for that visit, and the next follow-up appointment. All that information is being entered into the EHR by the nurse. Dr. Anderson then leaves the room and moves on to the next patient who's been prepared in the same way by one of his other nurses. In the meantime, this nurse stays with the patient. She reviews the plan, she prints up and reviews the visit summary, answers any questions that the patient has, and escorts them to checkout. Now, Dr. Anderson transformed his own practice, and many physicians have learned about him. He's been shadowed by over 50 other physicians who came to learn about his model of care. Most recently, just during the past year, he's left his practice to help large organizations develop this type of a care program. Most recently, he's been working with the United States Army in 22 of their primary care provider locations. This is Dr. Kevin. Yes?
Can you talk a little bit about the economics of transforming the practice? How does it pay for the increased overhead expense?
Right. He has a very excellent paper. His extra staff was easily paid for by the additional visits. And we'll talk about that more in a second. But his costs were covered. In fact, more than covered. He's had a production that exceeds his costs. This is Dr. Kevin Hopkins. Dr. Hopkins is a young family physician. He's at the Cleveland Clinic. And when I visited him, he told me he'd only been out of residency for about a year and a half, and he was burned out. He was ready to quit. He felt overwhelmed. He knew he had to do something different or he was going to leave. Fortunately, he heard about Dr. Anderson's practice, and he went and spent time learning some of the techniques. And he brought his own program back to the Cleveland Clinic. Now, when Dr. Hopkins brought his own ideas back to Cleveland Clinic, he had to provide a business plan to justify the additional staff, just what you were talking about. He calculated that for the additional staff that he needed, it would only take seeing 2 more patients a day throughout the year to cover his costs. What he's found, now that his model is in place, that actually his access for patients increased from 21 to 28 visits per day. His costs were easily covered. In fact, his revenue increased by 30%. His model has been so successful that the Cleveland Clinic has asked him to spread that to other members of his department. And again, when I spent time with Dr. Hopkins and his MAs, I felt like I was where I wanted to be as a physician. This was a practice where people were efficient, people were enjoying their work. And when I came to the end of the day, I said, what do you want me to tell other people about your practice? And they said, tell them we're having fun in primary care. We're having fun in primary care. And I'll tell you, traveling around the country, you don't hear that very much. And it's not only the physician, but it's also other members of the team that are having increased satisfaction with this type of model. Dr. Hopkins told me the MAs are more fully engaged in patient care than they ever have been, and they are enjoying their work. They have increased knowledge about medical care in general and about their individual patients in particular. And I confirmed this when I talked with the MAs. They said, we come into work and we learn something new every day because they're right in there while the decisions are being made in the room with the physician. And they said, we really get to know our patients. Again, they act pretty much as the advocate and the patient's escort throughout the entire visit. So their relationships with the patients in that medical home have become much deeper. Another collaborative care model that we visited was the University of Utah at Redstone. Here they have a model which provides 2.5 MAs per physician. And I think this picture really captures, again, the strength of the model. Here you have the physician providing the undivided attention to the patient while the MA is in the room doing the important work of documentation, order entry. Another one of our sites was Dr. Amy Halpert. She's a family physician in Minnesota. She has a team that includes 2 nurses supporting her, again, in the room with her with scribing. She says, I get to look at my patients and talk with them again. We're reconnecting. Our patient satisfaction numbers are up. Our quality metrics have improved. Our nurses are contributing more than ever, and I'm going home an hour earlier to be with my family. This is Dr. Joe Kim. He's at the Office Practice of the Future. This is the Quincy Family Practice Training Program of the University of Illinois. They have a very robust team. They have 2 MAs and 1 LPN paired with each physician. Again, the MAs are doing the work in the room, scribing, order entry with the physician. The LPN is at the desk doing all that interval work that needs to be done between visits. The phone calls, prescriptions, and paperwork, and so forth. So, in summary, of the sites that we visited, 6 of them have a collaborative care model, and we've seen in each one of them access for patients increased by 30%. The costs were covered, and that was a good question you had. Satisfaction, not only for the physician, but other members of the team increased. Quality metrics improved, and across the board, physicians were going home an hour earlier, and they were not taking home that extra hour or 2 of documentation that we see so often across the country that's leading to the increased levels of burnout. I'll stop there. Does anybody have any questions? Yeah, Phil.
I noticed that all 6 were family practices. And do you think that there's a significant difference between family practice satisfaction and internal medicine satisfaction? Because sometimes it takes 2 people just to get the patient up on the exam You know, you find the same robust innovation and robust positivity in the internal medicine practices?
Well, I'll tell you, I think family practice is way ahead of us in terms of outpatient. They're working on the models they're way ahead of where we are. I don't think we saw, aside from our own, I don't think we've seen others.
Well, I think, Phil, that's a great question. And the question really is, in essence, can we do this in internal medicine? And I would say we actually need to do it more because of the fact that our patients are older, we'll have more complexity. So Tom and I have been doing this model for the last year or so. We've been thinking about it for 4 or 5 years. So when we heard about Peter Anderson, it was like, wow, we're going in the same directions. It was very similar to what we'd been wanting to do. And I feel that our care is so much better we can do what we call collaborative care 2 days a week, and 2 other days we do the traditional model. And so we can really contrast that in our own kind of daily rhythm. And on the days that we do collaborative care, where the nurse stays with the patient from beginning to end, I feel that those patients, they don't leave with that deer in the headlights look like, what am I supposed to do next? I don't feel so frazzled because the nurse and I are working together, and she's doing much of the recording of things and the billing, and she's there to explain over to the patient what we're doing. She will tell me some things that the patient had told her but then forgot to tell me during the visit. So it's a 3-way conversation when the nurse is in the room with us, with the patient. And I think our more complex patients are the patients that benefit the most.
I have a couple of concerns. For example, for lab work, my nurses, my assistants, that are MAs, are allowed to reprint the blood work that I order. But I wouldn't know how could they request blood work on my behalf if they don't know exactly the blood. They really don't have the training to do that.
Yeah, that's a great question. His question is, well, how does the MA know what lab to order? The decision is made by the physician. So, for instance, in our practice, at the end of the visit, I want to see the patient in 6 months, have the A1C. I make that decision. I just check a few marks, and our receptionist actually put that in. They do not make decisions. I make the decision.
With the scribe, for example, I heard that model in the past also. When I do my dictations with voice recognition, I write by a problem list, right?
Mm-hmm.
Hypertension, control, key present treatment, right? High cholesterol, and so on. I think that really requires a certain degree of complexity and training. I wouldn't think a scribe, unless he's highly trained, would be able to replicate something similar because it's really your thoughts, your blood, right?
Yeah, the question is, can the scribe really provide the complexity of the note that you want to provide for the patient? There's 2 things. First of all, in the scribing model, I'm saying what needs to be done, and the scribe is doing it. I will say in our own model, we have a hybrid, okay? So a lot of the information is put in by our nurses, but I always dictate also. So the complexity of the note is a hybrid. A lot of the boilerplate thing that you need to get in to the note, the information, is done by them. But the complexity of the problem for the patient, I'm dictating. So we have a hybrid. So I think there are different models, but that's a very good point because we don't want notes that are meaningless. We want notes that are rich and really provide what's going on there. So in our own case, I think the hybrid model really works. Yeah.
Have you applied this model to specialty clinics? I'm in rheumatology, and obviously this is all chronic care, and drowning people.
Right.
Yeah.
So the question is this model applicable to other practices and to subspecialties? And I'll tell you, I think that our surgeons in some ways are also ahead of us. I have seen this in surgery practices, and I think they're used to that kind of collaborative model. It's similar to in the OR. And I think we would understand it if we used a surgical metaphor. We would never expect a surgeon to gather up all their equipment out of the cabinets. We would never expect the surgeon to fill out the pathology requisition slip. But in outpatient ambulatory care with the cognitive specialist, we are doing the equivalent of that. And my own feeling is we are wasting about 60 to 70% of physician output in primary care and probably in many of the medical specialties. What I think we'll do is we'll take one more question here, and then we'll go on, and we'll have some time at the end, but I want to make sure we cover the basic material. And I saw a woman with a hand up. Yes, you.
How do patients feel about putting their lab drawn and
That's an excellent question. The question is, what if the patient needs additional lab when they get to the visit? And we've studied this in our own practice. The most common cause of that is when they come in, you already have a lab, and they say, I'm tired, and then you want a TSH, okay? We've looked at our lab, so it's less than 3% of the time this happens. We've actually had the numbers. And with the TSH, they're tired today, it's been a new problem. I'll send them down for lab, and then they can call back, or I'll call them with that particular one. So it's not 100%. But what you always have to do is look at what's the big picture. We're dealing with 95% of the lab is done ahead of time, and that's really, really helpful. But that's an excellent question. Okay.
And the way I usually do it is I'll say, oh, I think it might be a good idea to do a TSH. Would you mind if we sent you back down today for an extra blood draw? But it happens so infrequently because most things in chronic illness you can predict. Okay, so the fourth challenge, computerized technology that pushes more work to the clinician. Here's a physician in Des Moines. The task list is unbearable. I spend an hour and a half clearing out my task list before I leave, and then another hour and a half at home after the kids go to bed. And the innovations that we found here are around finding efficient forms of communication, both in terms of inbox management and in terms of verbal messaging. So back to Fairview. Fairview had as one of their initiatives empowering the nurses and the medical assistants to filter the inbox. And so now, instead of going directly to the physician, all the messages first are filtered by the nurse or medical assistant, and they pull off all those messages that they're capable of managing. And only those few messages that really require a physician level of engagement are sent on to the physician. And they have found that by doing this, they've been able to reduce what they call the backpack of work that the physician takes home every night from an average of 90 minutes to just a few minutes per night per physician. I also wanted to show in this picture line of sight. So this particular clinic at Fairview was designed entirely with a patient-centered model of care and with efficiency in mind. And so you can see where the MA is sitting. From line of sight, she can see the status of all of the exam rooms that she's responsible for. Many of our study sites began their electronic journeys understandably thinking that asynchronous electronic communication would be more efficient and would be a better way to go, but then have paradoxically come around to recognize that verbal messaging is actually really efficient and really effective as a form of communication. And physician and nurse or physician and MA can go through a lot of messages in a very short period of time and eliminate a lot of the work in the inbox in the first place and reduce the amount of that electronic e-messaging going round and round in a thicket in the practice. This is the ambulatory practice of the future. This is one of the practices at the Mass General in Boston. And the innovation I wanted to highlight for you here is a semicircular desk. And this physical element has changed the way they interact with their patients in a degree. Because the physician and the patient can face each other. They can look at each other face to face for most of the visit. It's not that the doctor's having to look over his shoulder at the patient while he's looking at the computer. But then when they need to, they can turn and engage in a three-way conversation with the electronic information. This is a variation on that theme. This is at Iora Health, which has a clinic associated with Dartmouth-Hitchcock. And what I want you to see here is not only the semicircular desk, but also that very comfortable, intimate relationship here in the room. The physician is giving the patient his undivided attention. The electronics are there, but they're somewhat pushed off to the side, and he's really focused on that patient. Now, in this model, they also have a health coach, an MA, who does the pre-visit with the patient, who stays with the patient during the physician component of the visit, then stays afterward to wrap things up, and then contacts the patient between visits. And so the health coach is here. And in this component, in the doctor component of the visit, the health coach then is recording much of the visit. And just as you had asked before, then the physician will probably add a few notes in addition, but most of the documentation is done by the health coach. So the fifth challenge is teams that function poorly and complicate rather than simplify the work. And the innovations here are around creating forums for communication through co-location, through morning huddles, through weekly team meetings, and through taking a systems approach to workflow planning. So this is what they call a flow station at North Shore Physicians Group in Boston. And you can see that the physician and the medical assistant are seated side by side. I've been to some practices where the physician says, I never see my M8. Or I never see the nurse. This flow station gets around that issue, and they can be in communication. They're working shoulder to shoulder. When an issue comes up, she can just ask him a question. They don't have to create a long, complicated email message that goes back and forth between each other, and it eliminates a lot of work. She can be on the phone and just turn to him and ask a question and then complete the work of that phone call right at that moment. So when I talked to the leaders of North Shore Physicians Group, they told me about a senior member of their faculty who had a large practice, over 2,500 patients in his panel. And within a few months of starting in this physical setup, he was going home now without an hour or two of work to be done from home. This is South Central Foundation in Alaska. South Central Foundation is a very interesting clinic that works with a native population. They recently were honored with a Baldrige Award for their work. Their care model is based on what they call an integrated care team of a provider, a nurse, a medical assistant, and a clerk. And those 4 people are seated next to each other in this workspace. And in fact, there are 3 integrated care teams seated in this workspace. And then they are surrounded by an extended care team that includes a pharmacist, a social worker, and a nutritionist. So as the day is going by, if a nurse or medical assistant has a question, they can go right over to the nutritionist and ask, or ask the pharmacist about something. If there's a patient who has a special need, they can bring the social worker right into the room to make a warm handoff, and the social worker might get started with that patient with something and then arrange for the patient to return for a dedicated visit.
Can you talk how they pay for that model?
So that's an interesting question. The question is, how do they pay for that model? One of the things that we found in our practice, in our study, was that those practices that are under primarily a fee-for-service model were more likely to have 2 or 3 clinical assistants per physician and do more of the pre-visit planning and the sharing the care with scribing and that kind of thing. Those practices that were supplemented in their financial arrangement or had some sort of global payment were more likely to have this extended care team, as we're describing here. So I did notice that difference, that we saw that extended care team much more commonly in practices that had additional revenue streams beyond fee-for-service. So this is the ambulatory practice of the future, and they are receiving revenue from the greater organization for this model. And they have a similar kind of bullpen situation where workers are seated next to each other. They also have line of sight. You can see that the exam rooms are on the perimeter of this workspace so that everyone can see the status of those exam rooms throughout the day. This is the University of Utah at Redstone. Here's the group having a morning huddle. They're getting a status report, who's in today, who's out, what are the special needs that they might be anticipating for the day. So for situational awareness and to help individuals work more smoothly together. There are also team meetings that we have ourselves do and we observed in multiple sites that we visited. And the idea here is that not only does everyone come to work every day to do today's work, but we all come to work, the nurses, the medical assistants, the physicians, the receptionists, we come to work on making tomorrow's work better. And that team meeting is one of the ways to accomplish that. Here's the team meeting the day I was at Iora Health. And that particular day, the medical assistant, or what they call the health coach, was leading the meeting. And they started out by saying, we all own the outcomes of this practice and we all own the meeting. And sort of the distributive leadership that they had integrated into their culture. This is Theta Care again in Wisconsin. This is a clinic manager making what are called her weekly cell lead rounds, looking at data related to this is with the cell lead who takes care of the medical assistants and the other cell lead who takes care of the phone banks. And every week they walk through and look at their data and try to strategize on ways to make it better. Well, when you go to Theta Care, as I mentioned, it's almost like being at a sporting event. The culture is palpable. And I think one of the things that has contributed to that is they have adopted Lean as their change methodology. And all the staff from the first hire are trained in the language and the methodology of quality improvement. And when you go there, you get that feeling. You know that everybody is pulling in the same direction. There aren't often silos, but they are working all together in the same direction. And I had the sense that they have this remarkable capacity for change. When you go to Theta Care, every single hallway is lined with data. They track data around quality, around efficiency, or the finances, and around satisfaction. And then they're transparent with that data. They even in their waiting rooms have data that they share with their patients. And some of the data is around patient performance in terms of timeliness for their appointments. This is what's called Mission Control Room at Harvard Vanguard, also in Boston. They too use Lean as their problem-solving technique. And every 2 weeks, a new workflow is brought into this Mission Control Room, and they'll use Lean techniques to try to improve that workflow. Here they're using fishbone techniques. And then I wanted to come back to South Central Foundation in Alaska, I think in part because it's about the same size as our practice. It's 115 physicians, but they have 26 improvement specialists. 26 improvement specialists with a group of 115 physicians. So if a team has a problem that they want to make better, they can call on an improvement specialist. They can call on a data analyst. They can determine what the current state is. They can look at that data. Then they can map out using process mapping a way to get to a future state, a state that they want to be at. And then they can initiate that change, and then using these improvement specialists, go back and see if their improvement, if their change was an improvement. Yes? Can I give an example of that?
We're going there this summer.
You know, we're going there this summer. David Margolius, who is a resident here at UCSF, is the one who was there. So I can't give you an example that they did. I can give you an example from our own practice. So in our own practice, we wanted to improve our timeliness. And so we did process mapping with sticky notes, and we used the side of the wall, and we listed every step from when the patient calls in to make the appointment to when they arrive to who's touched them at every point along the way. And then we had everyone put down all the things that would slow that down. And we put those stickies on the wall, and then we strategized on each one of the barriers. We picked out the ones that we thought would be the highest yield to fix and the ones that were within our control to fix. And then we did some cycle time studies before and after. So that would be the kind of example. So I'd like to close, and we'll still have time for more questions and conversation when we've finished here, by just extracting some of the key lessons that we've pulled out of this work for ways to decrease physician and staff burnout and to increase the joy in practice. And the themes that we found were, first, sharing the care among the team, particularly robust in the 2 or 3 to 1 staffing model. And important here is to emphasize that the stability of that model, the same people working together day after day. You get to, as you would expect, you know what the other person is going to do. You know what the other person needs. You can't reproduce that if it's a different person every day. And in that idea of sharing the care, it's moving away from the physician doing everything to sharing that care from physician-centric to a team-based model. The second theme is clear communication and creating the infrastructures that facilitate clear communication, whether that's through co-location, through team meetings, through daily huddles. And then to take a systems approach to planning, pre-visit planning, planning around the prescription management, using workflow mapping to improve the processes of our work. So I wanted to go back to those 3 good men that we started with. And I had the chance to visit Dr. Ben Crocker again in his practice. I'd first visited him in 2008. He's the one that had said working at Starbucks would be better. And then he moved to a new practice within their system, the ambulatory practice of the future. And he wrote me this back. The biggest difference is team, culture, and time. Time with patients to better understand who they are, their story. I wouldn't trade that for anything. I'm loving it. And so I think our work going forward as general internists, as rheumatologists, as people concerned about our patients and about our U.S. healthcare system, is to think about how can we contribute to transformation so that more of us can move from feeling like working at Starbucks would be better to I'm loving it. And I think the good news is that the things that help to transform practice and eliminate burnout at the front lines, at the patient care level, improving the quality of care, improving the patient satisfaction, improving the efficiency and the wise use of resources and the physician satisfaction, those are the same things that will also help transform our practice at the 60,000 foot level. The things that Ezekiel Emanuel was talking about at the high level are in alignment with the things that we found at this most granular level. So we think that creating joy in practice is really important, and it's important not just for physicians, but also to try to achieve the triple aim. So with that, I want to open it up for your comments and questions, and we'll start with you in the back. You, yes.
In our group, our compliance people have told us that while the MA can enter the history or the chief complaint,
Yes.
only the licensed practitioner can do the history, the review systems, physical exam. But you have a scribe sitting there doing that. How do you, since it's the same person,
Sure.
how do you make that work? I mean, I'm reluctant to log on my log on and have to do it because it looks like it's me because rule number one in my practice is I fail.
So the question is,
Go ahead.
The question is, what about compliance? And we've got a national compliance expert in the room here, so we'll turn to her for her assistance. But my understanding is you're absolutely right that the MA or nurse is only allowed to put in the chief complaint before you come in the room. But if you are in the room and they are scribing, they can scribe anything else. That it's only that they can't put in the HPI and have you not collect that information independently. If you collect that information independently, they can be the one who's physically keyboarded it in. So
We have a disclaimer on when our nurses do it, there's a disclaimer at the bottom. This has been done as a scribe and assistant to the physician. So it's automatically there. It's just a button that's there.
for some practices, the scribe will record much of the history of present illness. In our own practice, their nurses have been trained to record the HPI. However, almost always, we will each put our own addition to that, because it's those subtle pieces that I really want to remember and catch up on the next time.
Again, for us, it's kind of a hybrid note.
Janine, did you want to address anything that...
There are rules and regulations about scribing that are pretty well documented by the Center for Medicare and Medicaid Services, by CMS. Almost anyone can be a scribe for you if you are telling them what to type in for you. But it's true that you need to be in the room doing it. I can't quote to you the scribe regulations. I just know them off the top of my head. There's still a lot of concern and fear around electronic medical records, the issue of people in EMRs documenting under your login. And so I will think that that is something we are having a lot of discussion about at my institution.
Might talk about
I certainly understand why your compliance folks might be having concerns about it, because it hasn't been well defined by CMS. The challenge with EMRs is that it's very easy to track exactly who did what. And so the issue of someone entering stuff under your login could be very concerning to a compliance person who is very conservative in their views.
And I will just clarify, in our own practice, the nurses have a laptop, and we have a laptop, so they're doing everything under their login, and whatever we do is under our login. So there is an electronic audit trail of actually who keyboarded what. But we're quite confident that we are following CMS regulations in the way that we do this because of the fact that they are scribing what we are collecting from the patient. Let's see. In the guy in the second row. You had your hand up for a while.
Practice in Alaska that had the 26 improvement specialists. What's the professional background of an improvement specialist? I want to go find one. What would I be looking for?
Let me think about that. I think that they are often nurses who have been trained in quality improvement. I believe so. Yeah, guy in the front. Oh, I'll get you next.
Someone like me who's somewhat easily distractible by noise and at the end of the day has lots of stuff done. The co-location, I wonder about the sound level and the confusion level and how they can address that issue. Second question is a bigger issue. You hear about these kind of anecdotal studies. What is ACP or the government doing about improving the diffusion of this information? All these practices are drowning right now, and it doesn't seem like there's a very effective way other than saying, well, those guys over there are doing a good job. I want to see what they do.
Well, that's what we're trying to do right now. And this study actually is going to come out in the Annals of Family Practice next month in May. So you're exactly right. This has to get out there. This is what's going to save primary care, is these types of models. As far as the noise situation, I'll tell you our own situation. I have my own office, but much of the day I'm up in the front with my nurse and we're working. So much of the day, but when I want to be by myself and do things, we have the best of both worlds, I guess. So that if you're a person who can't stand, they get distracted, you have to do some work, you might have both. But ours, most of my time I'm with my team, but I can retreat to my own little place there.
And I notice we have about 4 minutes left by my watch, so we'll answer as many questions, but then we're going to be around, so don't worry if you want to say something. Go ahead. Yes.
The additional information that physicians enter in addition to what's described in there, do you do that in the room with the patient before you leave?
I do. I do all of my dictation. I want to have the entire visit wrapped up before I go. So all the dictation is done, all the results are reported, all the prescriptions have been done, the nurse does those. My dictation is done, I've done the billing, I've signed it, and I don't have to go back to it.
So the nurse enters in the computer and you dictate all in front of the patient?
Right. And I was nervous about dictating in front of the patient when I started it a few years ago, but I really think it's a very good thing. I make it a conversation with the patient, so it's a good thing.
We have transcriptionists.
Yeah, we tried voice recognition, but I found it very time-consuming. Yes?
How much time do you allow for a visit?
So typically in our own practice, we've been in practice 25 years, so almost all of our patients are established patients that we've had for a long time. We schedule on a wave, and we'll see one annual and one follow-up on the half an hour. And then we have some buffer time so we can see all of the work-ins that need to be seen. Yes, in the far.
One and two physician practices, are they, a lot of the examples are larger groups. And the second question would be, well, I've got you here. I get that all the time. When you see patients with residents, for instance, they lay out a huge agenda with the resident, and then as soon as the doctor talks to them, there's always, a chest pain that goes about that.
Well, so I see that as one of the strengths of having the nurse with the patient from beginning to end, to be their health coach and their advocate. One of their jobs is to help to prioritize what's on the patient's mind. And we have a pre-appointment questionnaire, so patients fill that out. What's your agenda for today? What are you hoping to accomplish? That kind of thing. And if it's covered top to bottom and all the margins are full, the nurse knows that one of her jobs is to help the patient say, which are the 3 that you need to talk to the doctor about today. And we have found that small practices have some advantages. They typically don't have quite so much administrative bureaucracy, so change can be a little bit faster and easier. And then they have the challenge of not having the pharmacist and the nutritionist
Dr. Anderson's practice, basically, he was in a group of basically doing this on his own. So he was not supported by his group, and so he did it a one-person practice in a sense. And it was great because he had so much flexibility on how he used his nurses. A lot of places, you get the bigger places, there's so much bureaucracy about what the nurse or the MA can or can't do, you get locked into that morass. So a lot of times, smaller practices can move ahead quite quickly.
I think we're going to stop now because I think it's 8 o'clock. And thank you all for your attention, and feel free to come up and ask questions.